Good evening, Professor Roland.
Good evening. How are you? Salam alaikum.
How do you say good enough, or we say it good enough?
Yeah.
How are you doing?
I'm okay. And
I enjoyed talking to you yesterday.
I'm very sad to see you wearing mask.
And next year we'll be together, as we say, inshallah, and it will be a physical meeting, hopefully. I have with me Professor Mukhtar Ashraf Makour and Professor Ahmad Qurra, and we're trying to make some social distance, and we'll enjoy your talk, Professor Roland. So I'll leave the mic for you, and it's you're going to talk about the anti-inflammatory relievers, and that will be kind of a roundtable discussion with the professors with us in this room. Okay, the floor is yours, Professor Roland.
Thank you very much, Mr. Chairman, dear colleagues. As we agreed on, I will speak for about 25-30 minutes to leave us enough room for discussion, and I'm really looking forward to the interaction with you. Now let's see if it works. I hope you can see my screen now. And the topic.
It's okay, Professor Roland. It's okay.
The topic of my talk is anti-inflammatory control and reliever therapy in asthma. And at the end of my talk, I will also shortly focus on some new developments in the field of asthma. Before and thank you again for the invitation. Trust me, I would love to be in beautiful Egypt now, but let's get the best out of this current situation and do it online. Here are my potential conflicts of interest. We are participating in quite many clinical trials, which is why you see all the big names on this screen now. When we talk about anti-inflammatory control and reliever, let's first focus on the problem. And this is what my patients always call the headache problem. They tell me I have a headache, I take a painkiller, and when it's over, I stop taking the painkiller. This is same in asthma. There is a sizable number of patients who do not think there is a need to take medication when they feel well. And what almost all of them want is something that provides them immediate relief when they have a problem. And once the problem stops, they stop taking the drug. This is why in asthma, the #1 drug worldwide is a rapid-acting bronchodilator, a SABA. And the drug, which is, in my opinion, the best way to treat asthma, the inhaled corticosteroid, the main breakthrough some decades ago. I'm old enough. I was around when we did not yet have inhaled corticosteroid. This drug is not very popular because I keep hearing, oh, when I inhale this drug, I don't smell anything, I don't taste anything, I don't feel anything, and it doesn't help me at all. However, and this is shown on this slide, there are two problems. The #1 problem, we know that patients who only rely on reliever, left-hand side of this slide, the more reliever we prescribe, the higher the risk to have severe events and even to die. And same time, right-hand side of the slide, the least number of inhaled corticosteroids we prescribe, the higher the mortality risk. And this goes hand in hand with the fact that until very recently, and I'm part of the GINA committee, so it's my fault as well, we recommended as step #1 a SABA alone, a bronchodilator alone, even though we know that it's a chronic inflammatory disease. And then if patients have a slightly higher treatment intensity, step 2, we suddenly have to tell them, yeah, but the drug you were taking, it immediately relieves your problem. This is not your best drug. You should take something different, the inhaled corticosteroid. However, this is something where you have no immediate feedback. This is a problem, and this is why in China, for a long time, we were discussing how can we change the situation. And this is even more so since we know that over-reliance on beta agonists not only, shown on the upper hand side of the slide, not only increases the risk of severe adverse events, but at the same time, long-term, the effect of the drug is going down. The more SABA you inhale, the least effective it is when it comes to relieving bronchoconstriction, when it comes to bronchoprotection, when it comes to treating airway hyperresponsiveness, and so on and so on. We know frequent or high frequency use of SABA is associated with a decreased effect of the drug. And just to again prove this point, this is a study which is just a few months ago. This was done in Sweden. In Sweden, they have a very good online system to record prescriptions of drugs. And in patients with asthma who collected 2 or more SABAs in the recent years, 30% of them were prescribed at least 3 canisters of SABA. And as I just showed you, the more SABA we prescribe, the higher the risk to die from the disease. And now, when I show this slide to my German colleagues, and I'm sure in Egypt it's the same, they will all tell me, oh yeah, but there are not many patients to whom I prescribe so many SABA canisters. And at least in Germany, I don't know the situation in Egypt, but at least in Germany, this is not true. This is a very recent survey among German general practitioners and pulmonary specialists, clearly showing that up to 1/3 of patients are being, depending on severity, are being prescribed 3 or more inhalers per year, putting these patients at risk. This is why, not only my opinion, but also in the opinion of the GINA committee, we need a better solution to this problem. And this solution is called the treatment with a controller and a reliever in the same inhaler. This is something you and I are doing for a long time. You all, don't ask me how many thousands ICS-LABA combination I have prescribed in the last 25 years. This is an extremely popular drug in Europe. And why? Because you have at the same time the LABA, smooth muscle relaxation, and the ICS, airway less inflamed. This is much better than just giving a bronchodilator alone, as you see here. And this is why when we thought about this picture in the GINA committee, we said, why not go for ICS Formoterol for treatment, chronic and reliever, because here you have an inhaled corticosteroid and a rapid acting bronchodilator in the same inhaler. So you get the best of both worlds. You get immediate symptom relief, and at the same time, you get a nice anti-inflammatory effect. And just to show the point, the Formoterol, the onset of action is as rapid as the onset of action of salbutamol, which, at least in my country, is the classic SABA prescribed by most doctors. So the onset of effect, the immediate, yes, it helps, the immediate relief for my patients is exactly the same. And this is why within GINA, we developed this new concept. If a patient has symptoms, and only if the patient has symptoms, we recommend inhaling a fixed dose combination of ICS Formoterol to provide immediate symptom relief and at the same time treat the underlying inflammation. When symptoms go down, treatment, patients stop. They stop taking the painkiller when they have no longer a headache. However, if after days, weeks, months, symptoms come back, they take the drug again. In my opinion, this is at the same time very effective and very intuitive. This is what patients want. I take a drug when I have a problem, and when the problem stops, I stop taking the drug. Now you say, okay, this is wishful thinking. Show me the data. And I can offer you 4 big clinical trials, 3 of them published in the New England Journal, 1 published in the Lancet. And I will just briefly show you 2 examples. Number 1 is the SIGMA trial, testing exactly the concept I just showed you. In the SIGMA trial, SABA only as needed, this is the blue column, is compared with an ICS Formoterol, in this case Budesonide Formoterol, only as needed. And in the third arm of the study, regular inhaled corticosteroid plus SABA as needed. What's the outcome? Let's just look at, for the sake of time, severe exacerbations. Clearly, ICS Formoterol, the red line on demand, is as effective as regular inhaled corticosteroid, regular budesonide, to prevent exacerbation, and by far superior to SABA, in this case, terbutaline only. So very clear. There has been another Sigma trial, and when you combine these two trials, this is study, an analysis done by Eric Bateman, presented 6 weeks ago at the European Respiratory Society meeting, online only, and he analyzed the two Sigma trials together, clearly showing ICS Formoterol and regular inhaled corticosteroid, both are very effective in preventing exacerbations. However, with ICS Formoterol only on demand, the ICS load, the steroid load, is much lower, in this case, 78% lower with ICS Formoterol as needed. So patients get what they want: symptom relief, prevention of exacerbations at a much lower exposure to inhaled steroids. However, when I show this data to my German and European colleagues, immediately someone raises their hand saying, no, I don't believe the data. This is a controlled trial. So everybody has 100% compliance. This is not real life. This is why the novel START study was done not only, but mostly in New Zealand. They tested exactly the same concept in a study partially funded by the New Zealand government in real life. So the patients knew which drug they were taking, and the doctors knew which drug their patient was taking. And you see, it's a partly independent study because you have drugs from two companies combined in one trial. You have budesonide Formoterol from company A, and you have salbutamol as needed from company B. With this exception, it's the same concept, SABA as needed compared with ICS Formoterol as needed, compared with regular ICS plus SABA as needed. And the outcome, let's focus on the left-hand side, is exactly the same. This is the exacerbation rate, the red column. This is budesonide maintenance or regular, and budesonide Formoterol, that's the blue column, exactly the same. And by far superior to albuterol or salbutamol in my country, by far superior. And this was surprising to all of us, right-hand side of the slide. If you only look at severe exacerbations, you see that budesonide Formoterol is even superior to budesonide maintenance for a very simple reason. If patients only have an ICS-containing drug on demand, when they are developing a severe exacerbation, they have severe symptoms, so they will inhale the drug very often, so they get a higher dose of the inhaled steroid, which in this case is exactly what they need. Severe exacerbation, higher ICS dose, ameliorates the development of a severe exacerbation. This is why when you look at the severe end of the spectrum, ICS Formoterol is even superior to regular ICS. Now, the next argument comes from my German colleagues. Yes, but if you give a steroid in asthma only on demand, you may undertreat the patient. You may not control the inflammation. And that's a relevant argument. So let's look at inflammation. And what's the best parameter to directly measure lung inflammation? It's nitric oxide in the lung. During the airway inflammation in asthma, the inflammatory cells produce nitric oxide. So you can use nitric oxide to measure inflammation. And as you see on this slide, in patients both with ICS Formoterol and ICS regular, the red and the blue line, the inflammation is controlled as well. So there is no difference. And again, by far less inflammatory changes in these two arms compared with albuterol, salbutamol only. So also inflammation is controlled. We are talking mild patients, so they don't need so much steroid to control the disease. This is why we, within the GINA committee and the editorial person from the New England Journal, they completely agreed with our perspective. Patients with mild asthma should not and no longer treated with SABA only. They should rather be given an ICS Formoterol, or if you prefer, fine by us, ICS maintenance plus SABA on demand. These two strategies are able to reduce the exacerbation risk by about 50% in a perfectly safe way, no safety risks. And this is what we consider a population level risk reduction strategy. This is what you are aiming at when you are treating hypertension. This is what you're aiming at when you try to lower blood lipids. You want to prevent serious events. And this is why GINA committee is now recommended ICS Formoterol or regular ICS plus a SABA in steps 1 and 2 for patients older than 12 years. Why only adults and adolescents? Because we so far do not have any data in children. And this is why most recent, that's the 2020 version of the GINA recommendation, why in steps 1 and 2, our preferred treatment option is an ICS Formoterol only on demand, and as an alternative option, low dose inhaled steroid on a regular basis plus a SABA on demand. Very clear, steps 1 and 2, you cannot make it the life easier for your patient. This goes in line with something we are doing already for quite some years. And this is what we, and I'm not sure how you do it in Egypt, but we in Europe, we call it the single inhaler maintenance and reliever therapy approach. And the abbreviation for it is SMART. What is SMART? SMART is an alternative to conventional asthma treatment. Let me just briefly show you the difference. Here, this is conventional asthma. You treat patients with a little bit more severe disease, ICS LABA, regular morning and or evening. And if in between your patient has a symptom breakthrough, you add rapid acting beta agonist, a SABA on demand. Perfect, fine. Many of my patients do it like this. The alternative is the SMART approach. Here you also give an ICS Formoterol, so an ICS LABA, but only with the LABA Formoterol. You give an ICS Formoterol morning and or evening, and if in between patients have symptoms, you just tell them take the same inhaler if you have an additional problem and inhale more from the same inhaler. So this is why one inhaler, single inhaler is enough to control the symptoms of the patient. This makes the life of patients and of me, I have to explain only one inhaler, makes the life of my patients and my life much easier. Does this concept works? Yes. My good friend Klaus Rabe from Hamburg in the north of Germany, he showed already 14 years ago that this concept, when it comes to the prevention of exacerbations, is superior to a SABA only. This is the blue line on top, or compared to Formoterol plus Budesonide. This is in the middle, the blue line, and the SMART line is red. You prevent at least 50% of exacerbation. And this does not go at the expense of asthma control. Asthma control exactly the same, no matter if you give salmeterol, fluticasone, so ICS LABA regular plus SABA, or Budesonide Formoterol regular plus SABA, or you give a SMART approach. The asthma control day is always the same. And when it comes to exacerbations, this concept is, no matter how you look at it, always superior to either the same, a higher, or a much higher dose of ICS LABA. Why is this the case? Because patients always get exactly the right amount of additional ICS inhalation. So you go like an autopilot in an airplane. You always give exactly the right ICS dose, the dose the patient needs in a specific moment. Shown here in two trials, the COMPASS trial and the AHEAD trial. You get, with a lower overall steroid dose, you get a superior effect on the frequency of exacerbation. Again, not at the expense of airway inflammation. Ian Pavort has already 10 years ago done a nice study comparing the different concepts, conventional and SMART. And as you see here, there is no difference in the phenol levels, the exhaled nitric oxide. So SMART does not come at the expense of an increased inflammation, and SMART does not come at the expense of an increased safety risk. ICS Formoterol, you know it so well. This is that we have many different combinations now. They are as well tolerated as all the other ICS LABA combinations. So there is no additional or unexpected safety risk. And this is again why Gina in steps 3 to 5 recommends a smart approach as needed ICS Formoterol on demand on top of regular ICS Formoterol as the preferred reliever option in steps 3 to 5. So even in patients with severe asthma, simply because this new approach is so and highly effective. And to finish this, I'm in this business now for more than 30 years. Had you asked me in the late 80s when I started working as a doctor, and this was a time when we had theophylline and we had corticosteroid tablets and anything else, had you asked me in 1985, what is your wish for the future? My wish would have been in asthma, I want a highly effective treatment. I had a dream is with at least one or maybe two inhalers, controller and reliever in one inhaler, easy to explain and understand for my patients. And this dream has now come true. So I think we have made a major step forward in treatment of mild to moderate asthma. And now let's finish, give me 2-3 more minutes. Let's finish with some very recent advances that we discussed yesterday when we prepared for this session. Number one is triple in asthma. I think triple treatment is relevant not only in COPD, but clearly also in steps 4 and 5 in asthma, as you show here. Gina clearly recommends in patients who cannot be controlled with an ICS LABA, the addition of a LAMA as the preferred option to increase treatment intensity. So far, only tiotropium is approved in this indication. Why does it make sense? At least I learned it already in medical school. It is always better to add a second drug with a similar clinical benefit rather than increasing the dose of one drug too high and then just generating side effects. This is why a LABA and a LAMA in asthma and of course also in COPD are an ideal combination. Combining bronchodilators makes a better clinical outcome for equivalent or lesser side effects. This is more so, and this I learned from a good friend, Peter Barnes, one of the most famous names in pulmonary medicine. He told me already 20 years ago, the receptors for beta agonists and LAMAs, they are differently located in the lungs. This is why it's good to address the receptors in center and in the peripheral lung with two different drugs. And we can also do this both with conventional and with a smart approach. When you go for the smart approach, that's the bottom of the slide, you just add a LAMA on top of the ICS Formoterol. And if you want to have a triple treatment, we already have it in Europe. I learned it's not yet available in Egypt, but soon will be. You also need 2 inhalers, and you need to add a SABA on top of a fixed triple combination. So triple is now available for also patients with asthma. And finally, let's say 2 words about severe asthma. Also a very, very attractive development. If you want to learn more, this is a booklet that can be downloaded from the GINA website. It contains everything you need to know about difficult to treat and severe asthma. And once we confirm that it's truly severe asthma, we have to identify, is it mostly allergic or is it eosinophilic asthma? This is the important choice, because based on this decision, we can then prescribe monoclonal antibodies. I know they are not so widely used in your country, but for the patients, we can provide them with, they make a real difference. If they have severe allergic asthma, it's mostly anti-IgE. In the eosinophilic world, it's anti-IL-5 or IL-5 receptor, immediately lowering the number of eosinophils. And the most recent addition is dupilumab, an anti-IL-4/13 antagonist, also focusing on eosinophilic asthma. These drugs make a major difference to our patients with severe disease. I always tell my colleagues in Germany, evaluate treatment response after 4 to 6 months. Consider all the parameters that are relevant for your patient when you think about response or non-response. Also, that's a very important message. Not every biologic works in every patient. And I think every patient at least deserves a second chance. So if drug A doesn't work, at least give it a try with a different drug with a similar mechanism of action. Unfortunately, and this is the only bad news, these drugs, they work perfectly well long-term. However, there is no disease-modifying effect. This is why we have to continue treating the patients, and also importantly, we have to maintain inhaled treatment. This is what I wanted to tell you as a basis for our discussion about new concepts and new approaches to treat our patients with asthma. Thank you very much for your attention.
Thank you, Professor Ronald Bull, for your nice presentation addressing the importance of the anti-inflammatory reliever policy and also the smart maintenance and the reliever therapy of asthma and the concept of triple therapy in asthma, and also giving a hint on severe asthma and biological therapy. We really like your lecture and illustrated by the studies. I would first of all, I want to say a comment about what I call it's the window of opportunity, especially when the patient had worsening asthma symptoms before the exacerbation. When I apply the policy of reliever and maintenance and reliever therapy, you can abort the exacerbation before it occurs. On the contrary, if you are going to give the SABA, it will only attack the symptoms, and you at the end you will give oral corticosteroids. So I think in daily practice, I admire the smart approach as regarding maintenance and reliever therapy. So I share with you this thing. Do you rely on this in the daily practice in patient with GINA step 3 or 4 in your daily practice of the patient?
Yes, I rely, for most of my patients, I rely on, if they have very mild disease, I mostly rely on ICS Formoterol only on demand. And if they have more severe disease, I just switch to telling them take 1 inhaler every morning and or every evening, and more if needed. There is, however, a group of patients, for whatever reason, they prefer a constant maintenance treatment. And in this case, you can always give either an inhaled steroid or an ICS LABA once or twice a day as a basis. That's perfectly fine. And you know the rule, never change a winning team. If you have a patient who is happy with an ICS LABA for 20 years, of course, I don't change the regimen. I keep the patient happy. But for patients I start new, I try to go on these more flexible and at the same time more effective treatments.
Anyone want to comment? Okay, Professor Mutwalli. Okay. Yes, please, Professor Mutwalli.
Thank you very much, Professor, for your interesting lecture. I have a problem with the patients who takes this smart approach, is that the patients start to rely on this and I lose them on follow-up. I mean, if I tell them come after 3 months to follow up your asthma, they come sometimes after 8 or 9 months and they told me, well, I knew the rule of the game. If my asthma gets worse, I tell them that asthma is like the sea. If the waves are high, then you should go high with your treatment, otherwise you will drown. And they do this very well and they're very intelligent. But do you have the same? I mean, do you find some patients who don't come regularly because they are really totally controlled on this smart approach?
First of all, congratulations. I very much like the way you pronounce this. If the C is high, you take, I like this very much. I always hear from my patients this comparison with headaches. Yes, in some patients, I have the same experience. For many patients, and I call them the super responders, this treatment is very effective and it provokes them not to come see me. This is why I always tell them I want to see you if they have more severe disease every 3 months. and if the disease is not so severe, at least twice a year. But I completely agree with you. If patients are perfectly happy with their treatment, they find it very hard to come see me because they say it's a total waste of time. You do lung function, then you tell me your lung function is wonderful. Do you have symptoms? No, bye-bye. And you just prescribe one new inhaler. And this is, I can do it with my family doctor. I don't need to come see you at the university.
Anybody wants to comment? So I have another question for you, Professor Ronald. As regarding the primary care physician, how do you taught your primary care physician as regarding using the Budesonide Formoterol combination as a maintenance and reliever? I read in one of the papers that they use the number of activations. If the patient is using less than 2 activation, so you can have the opportunity to step down. If he's using more than 7 activation, you can step up. If he's using between 2 to 7 activation, he continue on this policy. So this is an de-escalation policy. Do you admit this policy to the primary care physician, so to make it simple to them, the number of activation or inhalation they use?
Yes, actually, I like the numbers. In my country, on a regular basis, if there is a day or two where they take 1 or 2 inhalations more, that's no problem. But in my country, the usual ICS Formoterol combinations are approved up to 8 additional inhalations per day. This is still considered safe. If patients need more, it's better not to push the drug to the limit. In this case, I would rather add a second bronchodilator like a LAMA or some other drug to increase treatment intensity. At the same time, if patients they have a regular dose in the morning or evening and they never need as needed medication, then I would go down to the purely on-demand strategy. I would tell them, stop your regular treatment and just go purely on demand. These are patients with very mild disease. They do not need a regular treatment. But it's very easy for GPs. This is my experience as well. You have one drug, and this drug can be taken only as needed early on. And if patients have a little bit more severe disease, you have 1 or 2 inhalations regular, plus only on demand. This is very easy for GPs. They need to treat not only asthma, they also have hypertension and diabetes and so many different diseases. So for them, we need a simple solution.
Okay, thank you. Professor Matwali, do you want to comment?
Once again, Professor Matwali. In the ICS LABA use, we don't consider using the ICS LABA on need as a reliever, as a use of reliever. So if you use it 8 times per day, you just say that it would be safe and it's okay. But then how do you know that I need to step up my treatment, maybe step up the concentration of the inhaler, maybe I step up the Symbicort for 320 concentration or so. When you don't consider using the ICS LABA on need as a need for a reliever. So how do you know?
That's a very, very important question. Thank you for asking. In my opinion, the best parameter to tell me that something is wrong with my patient is when they need a prescription too often. You know, usually, I don't know how many inhalations are in a typical inhaler in your country, but I know how many inhalations are in a powder inhaler or an MDI in my country. So I know even if they take 2 or 3 additional inhalations on a daily basis, the inhaler should last for so and so many weeks. And if patients come back like every 6 weeks or every 2 months and need a new inhaler, I know they're taking too much of the drug. And I know we need to increase treatment intensity by either changing the dose or adding in a second drug. This is your best parameter. And of course, ask the patient, how often do you take additional inhalations on a daily basis? That's also a very relevant parameter that is also part of the asthma control parameters.
Okay, thank you. I want to ask another question as regarding, as we know that the Formoterol maximum dose is 72 microgram per day. But the patient variation, some of the patient in more than in less doses than that develop adverse events as tachycardia. So do you shift to the triple therapy at this point, or what else? I think that some of the patients may benefit of the SABA at this point as an add-on therapy because they are more sensitive to formoterol as regarding the tachycardia, or we put LAMA.
Yes, that's of course an important point. Formoterol is usually a quite well-tolerated drug, but there are exceptions prove the rule. There are patients, when they even see formoterol, they tell me, oh, my hands, there's tremor and my heart starts to beat. In this case, we can try a different strategy. We can try a different bronchodilator, or if necessary, keep the dose lower and add a second bronchodilator. In this case, I usually add tiotropium as a second bronchodilator, and then you can achieve the same clinical outcome with a less formoterol exposure. And of course, this is always the case. We're in medicine, not in mathematics. There is the patient who cannot tolerate formoterol at all. Here, you have to choose a different drug. And that's also very important. Of course, we have in the typical ICS formoterol combinations, we have different doses of inhaled corticosteroids. So some patients may need higher ICS doses, and some patients may get along with the lower ICS doses. It has to do with the intensity of the asthmatic inflammation. So if patient isn't happy with dose A, you may give it a try with a different dose.
Thank you.
So let me ask you a question, Professor Ron, because as you know that we usually appreciate what the patient recognizes as a device. And what we see in our practice is that that's the combination of drugs, you know, the long-acting and with the ICS, the device itself differs, and some people or some patients, they prefer devices over other devices. So I'll tell you something concerning my private practice, and I have a busy practice. Some of my patients, they don't appreciate, I know we're in the Astra Symposium, and they don't appreciate the turboinhalers. Why? Maybe because of the level of education. They don't appreciate they did inhale something. They feel they didn't inhale anything. Sometimes it's difficult for them to appreciate the technique of switching right and left and etc. You know, this technique. So I wonder, is this the same problem in Germany whenever or you would appreciate or you respect the words of the patient? Because whenever I get a patient in my clinic, and it's usually a chronic asthmatic, I have all devices in front of on my desk, and I tell them I use this and this and this and this, and I ask him a certain question, which one of them you prefer? I believe that a lot of our patients in our community, they prefer the MDIs because they feel the jet going in. So I don't know what's the situation in Germany, and I wonder how do you proceed with your patients?
In Germany, the situation is quite similar to what you describe. We have, first of all, to acknowledge that all the data we have in mild disease is only with budesonide formoterol. So at the moment, the really solid evidence in mild disease is only for budesonide formoterol. I will now say some brand names. These trials have all been done with Symbicort. The situation is different in mild to moderate disease, the so-called SMART approach. Here we also have quite solid data with, as you said, an MDI. This is from a different company. It's an ICS, not budesonide, but beclometasone formoterol, and the outcome is the same. So and I do it exactly like you do. I have on my desk, I have all the different inhalers, and I show them to the patient, and I said, what is, in your opinion, what would best fit your expectation? And then they may even give it a try, and then they choose what they would like to have. And of course, the SMART approach can also be done with an ICS formoterol in a meter dose inhaler. This works as well, and at least for steps 3 to 5, We have even some clinical trials showing that this is an alternative for patients who do not want to have a dry powder inhaler.
I think will be the last question, Professor. Just I wonder, in the GINA guidelines, they mentioned that if the patient received the salbutamol fluticasone, it must receive as salbutamol as reliever.
Yes.
Why not use ICS Formoterol also as a reliever here in this case?
This is, in my opinion, one of the most exciting questions we have to answer at the moment. I would love to do a clinical trial to test exactly this concept, because in my opinion, it makes perfect sense. However, you already gave part of the answer. We are discussing two different companies. So this is more a political or a diplomatic issue than a scientific issue. But trust me, we have had some patients, they just by chance, not because I told them, but by chance, they used the ICS Formoterol on demand and the ICS salbutamol as a regular doses. This works perfectly well. However, this is my personal opinion. It's not supported by clinical trial data, so we have to wait until we have more clinical trial evidence.
Thank you.
Thank you. I want to ask you a question about the role of pheno in daily asthma follow-up, especially in mild and moderate cases. In GINA, it does not appreciate to do this in daily practice, although it is very important when you are going to deal with a severe asthma patient and choosing the biological therapy. So do you find, what about this discrepancy? You say that in severe asthma, but in mild asthma not, although in most of the studies that you have mentioned in the slides, they use a reference of pheno as regarding the inflammation. So what's your comment?
Thank you very much. That's extremely important. I think in the future, the cost to measure pheno will go down, and then pheno will be available all over the world. The only reason why in China we do not recommend it for every patient is because we are aware that in many countries this technique is still too expensive. In my country, even Germany, we are a rich country, but in my country we mostly use it for patients with very severe disease. There it's a must. I think it also have a major role in more mild disease. If a patient tells me, hey, Prof, I take my ICS whatever 10 times a day and I'm still doing bad. And if this patient has high pheno, I know his compliance is poor. That's a very good parameter to tell me, is the patient taking the drug? And at the same time, is there room for improvement for a higher ICS dose? So I think pheno is also very important for mild disease. If you have it, please use it.
Professor Roland, last question, because I'm the old guy here. So
I'm also beyond 60, so don't tell me about age.
Okay, I'm not going to ask you about your age. Do you regularly check your patient with a type 2 inflammation or high and low? Or, I mean, if your patient is well controlled on the regular treatment, do you still go for the allergic, eosinophilic, whatever, or the mixed type 2 inflammation, or how do you do with the patients?
If my patient is happy and if the patient is well controlled long term, when they come see me, I only do the basic regular check. So I do a lung function and maybe once a year I do pheno. That's all. However, if the patient is controlled long term, if I'm convinced she or he is taking the drug on a regular basis, they're happy, there are no problems, fine by me, keep going, never change a winning team. However, if patients are unhappy, if they tell me, oh yeah, I'm okay, but then you see lung function is poor, pheno 55, I realize something is wrong. Then you ask him, what if you have to climb 3 flights of stairs? Yeah, Prof, now that you ask, and then suddenly you realize the asthma is not as controlled as they think. And then you have to start checking for eosinophils, you have to go pheno, then you do for hyperreactivity. Then I want to know the full picture before I recommend intensifying treatment.
Professor Roland, I really appreciate your presentation. On behalf of all attendees, professors, we all recognize your effort with us. And I'd like to thank Astra for inviting us. And we hope to meet physically, as we say, inshallah, by next year. Hopefully.
Inshallah, fingers crossed. And thank you very much.
Thank you.
Thank you.
Thank you very much.